Good afternoon, everybody. I have recognized a couple of names from attendees, so welcome to my friends there. And for those that don't know me, my name is Leigh Ruth. I am a board-certified child and adolescent psychiatrist as well as a general psychiatrist. I'm originally from New Zealand, so kia ora, which is hello in Māori, and welcome. Today we're going to be talking about pediatric psychiatry via telehealth. And I'm going to let you in on some of the things I'm doing now and what I think could be improved in the future. So this is pretty much my lifestyle right now with COVID. I'm 100% tele. But what I'm talking about today is a program I've been contracted on since August or July, where I have carved out half a day on a Friday morning to work with different pediatricians across Florida. So I'm an assistant professor at USF, University of South Florida. I'm also an associate course director in the medical school. I teach the last course of second-year med students on psychiatry, neurology, OBGYN, endocrine, skin, and bones. So it's the last one. We got our final exam done just before the university shut down for COVID, so that was a huge weight off my mind. I did my medical degree in Los Angeles at USC at the Keck School of Medicine. And then we moved, I have two kids, my husband. We moved to Baltimore where I went to the University of Maryland, Shepherd Pratt Health System, and did my general and then 2-year child and adolescent fellowship. From there I moved to sunny Tampa, Florida, where I currently reside and work at USF. So I'm doing a mix of clinical work. I have a clinic practice 2 days a week. I teach fellows and residents and med students, and I'm also involved in a mentoring program. And then a little bit of research as well on PTSD. All right, so my experiences with telepsychiatry really started in my fellowship program in Baltimore. I did both school-based and judicial telepsychiatry. So in the school-based system, I was doing a direct care model, meaning those patients were my patients. I prescribed for them. I talked to their parents. I was in 4 schools in Baltimore, very underserved area of Maryland. I was in 3 elementary schools and 1 high school, and I would rotate amongst these schools with a dedicated psychologist where I would every 4 weeks change which site, and then I could also go there every so often in person and meet with the kids. The juvenile justice system was a little bit different. It was solely telepsychiatry, and I would see kids that were in the juvenile detention center. And then starting in August, I have been working in a consultation model with North Florida Pediatrics, A to Z Pediatrics, and Suncoast Pediatrics. So I see 2 consults on a Friday morning. So the learning objectives today will be to become familiar with pediatric psychiatry, telepsychiatry, through the consultation program that I'm currently doing with the USF Florida Medicaid Drug Therapy Management Program and the CMS, so Center for Medical Services, Children's Medical Services, I should say. I also want to talk about screening tools that could be helpful for evaluating symptoms of ADHD, depression, and anxiety. Because I'm only with the child a short amount of time, the more information I can have beforehand is much better for me for diagnosis and treatment planning. And then to recognize when it might be helpful for you in primary care to refer youth to telepsychiatry for evaluation with a child and adolescent psychiatrist. I know that most pediatricians are doing a lot of mental health work already, and so just kind of trying to see where we can be more help to you would be great. So advantages of telepsychiatry, definitely high patient satisfaction, less time commuting for the patient, but also for me, and it also cuts the cost. It's very expensive to drive a patient drive their car all the way from somewhere in North Florida down to Tampa. It improves access for geographically distant patients. They only need to go into their pediatrician's office to be seen rather than coming all the way to me or to St. Pete to see Dr. Voya. And then it's easy for me to collaborate with the pediatrician. So I'll go over a little bit how I structure my sessions, but I get to speak with the pediatrician after every consult. And then kids are already accustomed to using screens. They are more than happy to talk to somebody on a video. So what is the evidence base for telepsychiatry? There's some evidence posted on ACAP, American Academy of Child and Adolescent Psychiatry, but basically equal outcomes and satisfaction with patients and parents, improved collaborative care. You can talk to the pediatrician very easily. The reliability of diagnosis is pretty good. I think I can make just about the same diagnoses I could in person, maybe a little bit limited. And then there's definitely high patient and parent satisfaction. Okay, so the models of telepsychiatry I've talked about today is a direct patient care model where I see the child and I prescribe and follow up. Then there's a consultation program, which is what I'm doing now with Medicaid and CMS, and that's where I recommend treatment to the pediatrician, and they are the prescriber for that child. I typically don't follow up then unless there's a question, and I'm always available to talk to my pediatricians that I've consulted. Sometimes I do see follow-ups. There's a couple of kids that I'm following because they can't get services near their community, and they're pretty high-level psychiatric needs. So this Florida Telepsychiatry Collaborative for Kids started in 2018, but it expanded in 2019 for additional pediatric practices in Florida. So now there are psychiatric and therapy services to 3 rural pediatric sites in Florida. So we have North Florida Pediatrics. They have 9 locations with Dr. Sam and Dr. Pam Santelices are the CEOs, and they're mostly like Tallahassee, Lake City, Live Oak. Then we have A to Z Pediatrics in Newport Richey with Dr. Lokesh and Dr. Desai. And Suncoast Pediatrics is in Largo, Florida with Dr. Sterling, Dr. Kano, and I haven't yet met, but Dr. Smith and Dr. Milas. Okay, so the goal of the program is to minimize barriers to seeking behavioral health care through the use of technology and also to facilitate collaborative care. The program collaborates with the National Center for Performance Health. They take the screening forms in and they coordinate telepsychiatry consults and put them on my schedule. The form comes in and they determine whether they need therapy or psychiatry or maybe both, and then they determine when they should see those services. The 2 psychiatrists working on the program right now is myself and Dr. Justina Voyas, and she is based out of the Rothman Center of USF in St. Pete. There's also a great service or a great web tool available called the USF Aunt Bertha Web-Based Resource Guide. So this is a guide that was launched in April of last year where pediatricians, anybody really, can search behavioral and physical health services, including community resources, housing, food banks, and transportation. So how I structure the 60-minute consultation, before the session begins, I meet with the nurse, and usually she will give me vital signs. I like blood pressure, heart rate, height, weight, and then the BMI percentage. It's also really important at that time that she or he confirms past and present medication. And I'll talk a little bit later that this has been one of the limitations. So first up, I meet alone with the parent, and that's usually for 20 to 30 minutes. I kind of want to hear from the parent what's going on, what their concerns are, and then I speak with the patient alone. And that, depending on the age of the kid, the development goes from either 10 to 30. Sometimes it's flipped and I have less time with the parent and a lot more time with the child, especially if they're a teenager or adolescent. Then at the end, I give recommendations just to the pediatrician for 5 to 10 minutes while the patient and the parent are waiting in another room. The pediatrician will then go and speak with the parents about treatment options and come up with a plan without me involved in that part. And then I send a completed write-up within 5 days to the program, and then they disseminate it to the pediatrician. So I wanted to share with you some common chief complaints that have come about. So far, since starting in August, I've had 34 consults. We'll see the numbers in the breakdown in a little bit. But the most common chief complaint that I have been seeing is a behavioral component. So, for example, disregard to others' learning, stealing, attitude about participating, not following instructions, crying. Behavioral issues, academic delay due to behavior problems, morning meltdowns, getting into trouble at school every day, meltdowns in class, hitting his head with his hands, breathing tic, outbursts of explosive behavior, hitting kids and teachers, screaming and biting other kids and teachers. So these are definitely problematic. Very common too is an ADHD chief complaint. No focus, acting out, possible ADHD. He loses his clothes while doing chores, or he makes himself late from running around. ADHD, developmental delay, aggressive and impulsive. And then there's also been a little bit of school refusal, kids that are not wanting to go to school. Another very common chief complaint is anxiety. For example, worsening anxiety, solid food avoidance since choking on chicken, not wanting to be alone, waking up at night scared in your recess, anxiety and can't go to school. And then depression, more so in adolescence and above. Depression, lack of sleep, diet concerns, bullying at school. And then one patient missed all of January because of depression. Along with behavioral concerns, there's the aggression. So anger issues, fighting at school, ADHD. Got into a fight at school and got 3 days of in-school suspension. He talks back at school, he has all X. And also self-injury. Not so common, but I have seen it. New self-injury and not doing well in school. And one time there was this chief complaint of psychosis, hearing great-grandmother's voice talking to her, which turned out to not be psychotic in nature. So over the past 8 months, I've seen 34 patients, 15 are female, 19 are male. You can see the breakdown. A most common age group is 7-year-olds and 12-year-olds. And this kind of makes sense to me. 7-year-olds are in first grade. Rather, it's hit the road. They've got to sit still. Kindergarten is over. And so here's where we can see some behavioral and attention problems. And then the 12-year-olds, this is where puberty is starting. So I think we see more of the mood disorders around this time. So the most common diagnosis has been ADHD. 25 out of 34 patients diagnosed with ADHD or confirm the diagnosis. 20 with anxiety. Very few had one diagnosis. I think only one child with ADHD had just ADHD. More commonly, it'll be 2 and maybe even 3 diagnoses. So there's definitely trauma diagnoses. I typically won't diagnose PTSD over one teleconsultation. It really needs to have further evaluation, something like the UCLA PTSD screen, or to meet with a trauma therapist to really determine if there's PTSD. Major depression, 4 patients. Oppositional defiant disorder, 4 patients. A lot of intrauterine drug exposures. What I see in my clinical practice, a few that have come through the telehealth consultation. OCD, autism, and then an adjustment disorder. So anxiety itself is kind of a lumping term. It's an umbrella, really, anxiety, and there's different spokes of the different kinds of anxiety disorders. We have generalized, 25% unspecified. Probably I didn't have enough information to really know what was the specific anxiety disorder. Panic attacks, panic disorder, social anxiety disorder, and separation anxiety. So some medications I have commonly suggested, a lot of stimulants, and most pediatricians have already started the kid's on some kind of stimulant, but maybe it's not working well for that child. There's been aggression or irritability, or it's not working well, or not enough weight gain or poor sleep. So of the 18 patients that I have recommended stimulants to, these are a mix of the different stimulants. I typically use brand names because the generic names are so similar when it comes to the stimulants. So Adderall immediate release, Adderall XR, Concerta, which is a long-acting methylphenidate, methylphenidate ER-ODT, which is Contemplar, and Daytrana patch, and Focalin, Focalin XR, Metadate, Ritalin, and Quilivan. So looking at this list, you can see that I have more in the methylphenidate class than the amphetamine class, and that is more of a personal preference that I have. I have found that kids tend to maybe get a little more irritable or on the amphetamine base, so usually I'll start with a methylphenidate. Okay, and then antidepressants. So I've started 17 patients. I've recommended starting an antidepressant, and mostly that is for the anxiety disorders. As you know, the SSRIs are good for both depression and anxiety. These are in alphabetical order, but anafranil, I've used clomipramine a couple of times for severe OCD. And then Lexapro, Prozac, Remeron, Zoloft are some of the ones that I've recommended. And alpha agonists are very commonly recommended by me. They often will go in conjunction with a stimulant. And clonidine, guanfacine, clonidine ER. Cat-Fe is a nice form of clonidine because kids tend to not get very sedated on it. And then there's also Tenex, which is a shorter acting. I'll use that at night for sleep. Someone had written here not recommending Vyvanse at all. I do use Vyvanse in private practice. I haven't started it as a out-of-the-gate medication during consultation just because I tend to use more of the methylphenidates. But definitely between Vyvanse and Adderall XR, I use that one as well. It can also come down to cost. Sometimes it's very expensive if the insurance company isn't covering Vyvanse. And Medicaid has pretty strict rules on what stimulant they're going to pay for first up. So if you fail 2 stimulants, you can usually get the other more expensive brand name stimulant approved. So sometimes Vyvanse falls under that it's not affordable. And then very rarely, but sometimes, I have prescribed antipsychotics. And usually this is for severe aggression or self-injury and autism. So I've used Abilify, Latuda, Risperidone. And sometimes the Abilify can cause a lot of weight gain. So we may have moved over to something less weight causing, like Latuda, Lorazepam. And then, of course, it's totally up to the pediatrician, their comfort level. So there's some pediatricians that really don't want to go the antipsychotic route, and that's fine. We'll try to manage with other options. So some technology challenges or challenges I've encountered. One of the big ones has been inaccurate information on current and past medications. So this is a biggie because as I'm interviewing them, I'm really thinking about what I might want to prescribe. And if it hasn't been said that they've been on something already, I may have been coming up with a plan based around that medication. So it's really important to get the current medications they're taking and dosages, and also past medications. So this is an area I definitely want to focus more on with the pediatrician, probably on the screening form. There's been a few technology fails. We have lost connection. We learned early on that we needed to set a longer timer for the appointment because suddenly we would get cut off at 60 minutes. And if it's really a difficult or challenging consultation, sometimes I'll go up to 90 minutes if we needed to. So we've learned to just make the timer longer. Sometimes they lose connection at the pediatrician's office. Very rarely have we not been able to continue either via telephone or getting the equipment back up. You just have to be patient sometimes. Another challenge are no-shows. Very rare. I think I've had 4 no-shows out of the 34 patients I've seen. But definitely there's last-minute cancellation. And this ends up leaving the spot open for no one filled it. So that's kind of a bummer when there's a spot open and they're not using it. So the platform I use is Skype for Business. That's the platform that we've been set up on. It's HIPAA compliant, Skype for Business. Right now, I'm using Microsoft Teams for most of the interactions through USF. That's the platform that they are using. Let's see, the unfilled appointments is problematic. And then having insufficient information. So maybe a child is in foster care and the parent really doesn't know much about them. That can be difficult if it's a first-time diagnosis, say, of ADHD, and I don't have information from teachers. That's a little bit problematic. And then one big problem that we're going to really try hard to address are the limited resources for referrals. So it's really hard if I'm thinking someone has autism to actually get them into testing with the ADOS in Florida, in rural Florida, because it's quite a specialized service done with a psychologist. Even ADHD testing is a little difficult to find. And then also IQ testing. A lot of that is done in the school, reading, writing, math, see if there's learning disorders, but getting the schools to do it can be challenging. And then to find relevant therapy. So if we have a kid with OCD, they really need a specialized therapy, cognitive behavioral therapy with ERP, exposure and response prevention. That is really the gold standard for OCD. But it's difficult to find providers in the middle of rural Florida to do these services. And then even parent management training, helping kids that are having behavioral concerns or get them into some therapy for ADHD so that they have a little more behavioral modifications. So that has been difficult to find. So possible improvements with these challenges would be to enhance the screening form for the current and past medications. I think now it's filled in by the parent, the medications, and I think it would be a lot better if the pediatrician filled that in, or whether we reach out and give another screening before the appointment date to get all of the medications previous and current that they've tried. I think having a backup computer that can be accessed is really important. And then calling appointments the week before, and then possibly, if they can, the day before to confirm. Even with that, we've had 2 no-shows even when they had confirmed the day before that they were coming. One time it was the parent simply couldn't get the child to come until a later date. They rescheduled. And the other time, I'm not sure why. To increase information for me so it would help me diagnose, I think it would be good to use screening forms. So we're going to go over that a little. It would be good to have screening forms for anxiety, depression, and ADHD. And then we are already partnering with USF Psychology, but we really need to hone these services and be able to offer through services, more psychology services, more therapy, and parent management training for patients. So screening forms I use to aid diagnoses. These are free, and they can be completed before the appointment. Often I've given these during the appointment or to give to them after the appointment, and then it gets faxed to me. I score it and add it to my note. So these are both aiding in diagnosis, but they can also aid in treatment. So for anxiety, I use the SCARED. We'll see this in a little bit. as well as for depression, the PHQ-9. You're probably pretty familiar with that. And then you're also, I'm sure, familiar with Vanderbilt. These are both parent and teacher. So for anxiety disorders, I use the SCARED. It's the Screen for Child Anxiety-Related Disorders. I like this because it breaks down the anxiety disorders into the 5 subcategories of panic, generalized, separation, social, and school avoidance. So it's administered to both a child and to a parent, and they go along and select out of 41 items. They select not true, sometimes true, always true. And then based on that, there's a scoring along the side. My advice, if you're going to use this form, is to always get the one with the coding along the side for panic, generalized, because it makes scoring it at the end a lot easier. Okay, it can be used for 8 to 18-year-olds. So this is available online for free, and it's 0, 1, and 2 of the scoring to set up the diagnoses, and then there's a total as well. So it's pretty easy to use, and I use it also to follow treatment. If we've started, say, an SSRI, maybe 6 weeks later, I could give them the SCARED again and really see. Anxiety can be such an internal thing that it's nice to have screening forms, especially for internalizing children or quiet children, because you could get a lot more information out of them. Now the PHQ-9, the one to use is modified for teens. So this is a 13-item self-completion screening tool, and it's designed to look at depression and suicide risk in adolescents. So I typically had used the CESDC, the Center for Epidemiological Studies Depression Screen. The only thing with that, it doesn't have any questions on suicide. So I do like the PHQ-9 for that reason. So 9 questions ask about depression, 2 about severity, and then 2 about suicide risk. This is the PHQ-9 modified for teens. It's fast to complete. American Academy of Pediatricians recommend using this annually. And a PHQ-9 score of greater or equal to 11 is very, very suggestive for a major depression. And then the Vanderbilts. The NICHQ Vanderbilt Assessment Tool is both a parent tool and a teacher tool. 55 questions, so it is quite long, but it reviews symptoms of ADHD, their effects on behavior and academic performance, but it also looks for other conditions like conduct disorder, ODD, anxiety, and depression. So it's nice with ADHD to have both parent and teacher information available to you. So this can be used for ages 6 to 12, again, free download. And this is what it looks like. It's a 0, 1, 2, 3 scale. Typically, I'll also use this to follow treatment with the stimulants. And if a child, I'll say to parents, these 2s and 3s, we're going to try to get down to 0s and 1s. So that's our goal. And the first 9 are inattentive symptoms, and the second 9 to 18 are hyperactive symptoms. So it also aids in figuring out, is this inattentive ADHD, or is this combined, or is it just hyperactive? With therapy considerations, USF has held positive parent strategies via Telepsychiatry. It was led by the psychology interns under the guidance of Dr. Heather Agazi, but we only had 1 attendee participate. And why I think this happened is because it was based in the pediatrician's office. There was a computer set up there, and I think there was some miscommunication that this would be kind of a looping video that parents could just watch while they were in the waiting room. But it was actually a live session with an intern. So I think we can utilize the psychology interns more efficiently. So what in the future might be good? There is a need for one-to-one therapy options that could be something we do, but it's not very scalable. You help one child at one time. It would be a lot better to be able to help more families at once and also be able to scale it and also have stepped care. So right now, USF offer a webinar, 2 webinars. One is a webinar. They were actually offering them in-house. You would come and do the program for 7 to 9 weeks for 0 to 5 and for 6 to 11-year-olds. Now with COVID, they have gone completely tele. And Dr. Agazi was saying she already has the Hot Docs, which is 0 to 5-year-old program for disruptive behavior and parent training. She already has this in webinar form. She has 5 hours of online modules already available. So parents would be able to do these modules ahead of time and then meet as a group for online Hot Docs training with the psychology intern. The same is available for docs K through 5, but so far this is not built in a webinar format, and it's something she would need to build. And that's for 6 to 11-year-olds. So I think that would be a great resource to start using. So offering stepped care is a really great evidence-based way to offer therapy. Typically parents will complete online modules first, and then they can check in either by phone or telesessions every 4 weeks for about 30 minutes. So for example, if they're doing this for what we use sometimes as coping cats, which we use for anxiety disorders in kids, they could go through this, and then the stepped care would be a psychology intern or therapist calling the family and helping them through what's been going on since trying to adapt these strategies. Group-based PCIT, Parent-Child Interactive Therapy, it's highly evidence-based for behavioral concerns, ADHD, to help kids with behavior disorders. It's usually 0 to, well, not 0, but probably like 2 to 7-year-olds can participate in this. And this could be group-based with 4 sessions led by a psychology intern via telesession with parents and their children. So the other issue is, I think, to really scale this, parents need to access the therapy services remotely or from home. Going to the pediatrician's office for weekly therapy sessions is very difficult. We are not working with any ABA providers through telehealth. I haven't found many that will do a ABA via tele. And in fact, even kids that are established with ABA right now, it's pretty much on hold during COVID because ABA is such a one-to-one therapy. And I can definitely get you a link for therapy programs and resources that I'm discussing. I can put together a resource sheet and send that out. Okay, so we're nearing the end. There's also, with Medicaid, you can ask for a case manager to help with behavioral health concerns. They can help identify resources, therapy, psychiatry in their area. So you can always ask for a behavioral health case manager. That is about what I wanted to talk about and share about what I'm doing with Tele. If you want information on how to connect with Florida's USF's Telepsychiatry Collaborative for kids, you can call or email Sabrina Singh, and she would be able to give you more information.
So we do have a question. Are you working with any ABA providers through telehealth?
So no, we're not doing ABA. I haven't found any ABA providers that are doing tele visits. It's very, very hard to access ABA therapy in general. The wait lists are really long, and it typically is center-based or even more beneficial is home-based, but it's really hard to find those services. So I think having a case manager would be beneficial to try to find ABA services. But in rural Florida, it's very hard to find that.
I was looking at another question
Okay.
before that about ABA. I'm not sure. It's saying, so the ABA is still happening through Florida Medicaid for her choice of provider to use telehealth. I'm not sure. I think you mentioned something about ABA earlier. Not working.
Yes, it's from Dr. Goldberg. So I think she's saying that it is still happening. So it would be great to know how to access those services. So I'll ask Dr. Goldberg to help me put that together on the screening. I mean, on the resource sheet that I can send out. Yes, I think community physicians definitely can take the Hot Docs course. It can help set that up.
Okay. And then there's a question about how is the reimbursement rate in collections?
So the good thing about doing this in the pediatrician's offices is that the pediatricians can bill for the service, so they're the ones getting reimbursed for the service. I don't bill for any of these services. I'm contracted. So I'm not sure how much the reimbursement is. From talking to Dr. Santelices, it seems that it is reimbursed. He does, get some money back.
Another question, can community physicians take the Hot Docs course?
Mm-hmm. Yeah, I think we can figure out a way for that to happen. Right now, parents can take the Hot Docs course, and that it's on webinar based will make it a lot easier to access it, so you don't have to come to Tampa and meet for those 7 to 9 weeks. And you're welcome to email me. My email address, ljruth@usf.edu. If you have any questions, there it is. Let me know. I'm happy to answer questions for you.
Okay. And we do have some more that came in. Okay. It is, who follows the patient after the initial prescribing? Is that the pediatrician who follows and consults with the psychiatrist on an as-needed basis?
Yes. So the pediatrician follows the patient after prescribing. They'll have them come in for follow-up 2 to 4 weeks later and follow up with them. Sometimes I've consulted again. I've done a follow-up. I have one coming up in a couple of weeks, a patient with bipolar disorder and OCD. So that's kind of tricky because the SSRI that can control the OCD could also make her get manic. So I'm following up just to see whether we should start lithium. So eventually, though, if she can't find a psychiatrist in the community, the pediatrician would continue to be prescribing medications for that. But I have a good relationship with my pediatricians, and they're always welcome to call me, email me, or set up a follow-up appointment. I think the beauty of the program is that I have been able to see 34 patients because it's a one-and-done kind of consultation. And usually in my write-ups, I'm giving different options. If this works, then do this. If this doesn't work, then try this. Usually 2 to 3 options. I try not to make it too complicated.
And then is there a scared for adult patients?
No, there isn't a scared form. This is only for children. And feel free to also write in what your greatest challenges are for behavioral health as primary care provider.
Okay, so I use Telepsychiatry to work with deaf and hard of hearing from FSDB and working really well. And then another person stated I use DoxyMe. So I know you were getting ready to talk about that.
Yeah, so Doxy, me works, Doximity works very well too. Just in private practice, not private practice, but my practice right now, we're using Microsoft Teams. But if that can't be accessed, sometimes we'll need, at this time during COVID, HIPAA has been a little bit relaxed, so we can use Skype, FaceTime if we have to be able to provide care.
Are there increased liability concerns treating patients with depression or ADHD remotely?
Well, with this model being consultation, know because the pediatrician is there with the patient and they are, following them up in person, and they're the ones prescribing. And then even with doing remote work with patients, when I telehealth into a direct consultation with a patient, immediately I have to ask them their location and write that down and make sure I know where exactly they are, because if there is a safety concern, we need to call police to go and see them. The other thing with kids is we always have to make sure there is a guardian or parent at home. That has happened once where the parent left during the medication management practice, the appointment. And that, if there is a safety issue, becomes a really big problem. If they're saying they're suicidal or they're hurting themselves and we need to tell the parent to take them to the ER or need to call an ambulance, they need to be there. But for the consultation model, the parent, the child, and the pediatrician in the office, they're all there. I haven't had to Baker Act somebody via the consultation program with pediatricians. That hasn't come up at this time, but we are prepared if it did happen to work with the pediatrician's office to get them where they need to go.
And we have a challenge here. One of my greatest challenges is getting families to apply behavioral interventions. Many parents have poor coping skills, some substance abuse or anxiety, depression. And when their children are upset, it is very hard for the parents to stay consistent and limits. Any advice?
So I struggle with that too. Even parents that are doing the programs, it's hard for them to stay consistent. They do have a lot of poor coping skills. So sometimes getting parents into their own treatment is helpful, but also just providing support and active listening, coming up with behavioral plans for kids. So that's where behavioral therapy is so helpful. Mostly this therapy for 5th grade and below is actually parent training. It's usually all about teaching the parent how to discipline and how to be consistent with their child. But this is one of my greatest challenges too, with seeing kids in person and with tele. Yeah, so if you are interested in this program, definitely do get in touch with Sabrina. Let me go to the bottom of there to find out more information about scaling this program. I think one of the biggest concerns too is a lot of specialized services don't take the insurance that the patient has, and that's really why we're going in, because we're not billing for it. We can see them. I know USF takes a bunch of insurances, but there's only 4 of the Medicaid programs we take. There's others we don't take. I know, UF, All Children's, they are not taking WellCare, CMS insurance since the change. Yeah, thanks for joining today. It was unique doing this to a live audience that I can't see. But yeah, do drop me a line if there's any questions about today, or if you just have any site questions that you want to run by someone. I'd be happy to help you out.